Hello, hi everyone. The topic of today's lecture for Year 4 students is TMJ dysfunction in edentulous patients. These are the learning objectives for this lecture. Now, moving on. According to GPT, temporomandibular joint is the place of union of two or more bones. That is a joint is a place of union of two or more bones. Okay. So joints can be fibrous, cartilaginous, or synovial, depending upon the way they articulate with each other. Now coming to the TMJ joint specifically, TMJ joint is the articulation between the temporal bone and the mandible. It is a bilateral, diarthroidal and bilateral gangliomoid joint. This means that it is a joint which exhibits two motions. That is, one is the pure rotatory motion around the terminal hinge axis, and second is a translatory motion. So this is what is known as gangliomoid. Diarthroidal means it is a rotatory motion around the terminal hinge axis which defines the centric relation. And the gangliomoid means when the jaws are protruded or mandible is open to the maximum limit, the condyle slides or glides forward and downwards. This is known as the sliding movement. So it is a arthroidal and gangliomoid joint. Okay, TMJ is a compound joint because it is made up of the mandible and the temporal bone, two separate bones, the squamous part of the temporal bone and the condyle of the mandible. Okay, as I mentioned, it is the arthroidal and gangliomoid joint, that is the rotatory and translatory movement. It is a multi-axial joint, that is can exhibit movements in multiple axes. That is, a patient can protrude the mandible, retrude the mandible, protrude the mandible in the left and right lateral excursion. It is a squamous dentary joint, that is, because of the squamous part of the petrous part of the temporal bone, and owing to the and because it is also influenced by the position of the teeth, that's why it is known as squamous dentary joint. And it is the articulation between the cranial bone and the mandible. That is, the temporal bone is a part of the cranium or the skull, and mandible and the condyle is part of the mandible. So it is the craniomandibular type of joint also. Okay, what are the peculiarities of TMJ? It is bilateral diarthrosis, that is, it is a joint which is not singular but bilaterally placed, because mandible is a single U-shaped bone. On either side of the mandible we have two condyles, and these two condyles simultaneously articulate with the petrous part of the temporal bone. So it is a bilateral diarthrosis, whereas all the other joints in the body, namely the shoulder joint, the elbow joint, the knee joint, the pelvic joint, they are all separate joints. Okay, the left and right sides are separated by separate bones, so that's why this is a peculiarity of the TMJ. Now the articular surfaces of the TMJ are formed by the fibrous cartilage instead of the hyaline cartilage, as seen is your knee joint, your pelvic joint. Okay, it is the only joint in the human body to have a rigid end point of closure. Now moving on, in contrast to the other diarthroid joints, TMJ is the last joint to develop in the human. That is, as opposed to your knee joint, your shoulder joint, your elbow joint, your pelvic joints. Compared to these, the TMJ joint is the one which, in growth and development, is the last joint to develop, and it develops from two distinct blastemas. Okay, the anatomical components. Now, TMJ joint, as we know, consists of two bones, that is the temporal bone and the condylar portion of the or condylar process of the mandible. Okay, so the part of the TMJ joint in the what you call temporal bone is known as a glenoid fossa or the mandibular fossa, which is the upper portion of the joint, and the lower portion of the joint is the head of the mandibular condyle. Okay, and here we have something called as a articular eminence, which prevents the anterior or movement or sliding of the joint. Okay, this is the end point. Beyond this, a normal TMJ joint cannot translate. Okay, so now coming to the glenoid fossa first. Glenoid fossa, as I mentioned, it is the superior or upper part of the joint, which is a component of the squamous portion of the temporal bone. It is the concavity, obviously, because the condyle is convex, which goes and articulates with this concave glenoid fossa. Okay, so anteriorly we have the bony prominence known as the articular eminence, like I just described in the previous pic, and the posteriorly the glenoid plane is also convex and with a raised eminence, as can be seen by the point A, which prevents the condyle, which prevents the posterior displacement of the condyle. Okay, so the posterior roof of the condyle, as shown over here, is very thin, and this posterior part of the glenoid fossa cannot sustain a heavy force. So that's why the condyle articulates with the anterior superior most position of the glenoid fossa. Okay, and the articular eminence is whereas the articular eminence consists of thick dense trabecular bone which can tolerate forces and prevents the anterior sliding of the joint. Okay, the posterior part is thin bone, the anterior part is thick robust dense trabecular bone. Okay, the steepness of the articular eminence dictates the path of the condylar guidance. So you can see here we have a concavity, and this is the articular eminence, and this steepness or the curvature of the glenoid fossa, that is from the center of the glenoid fossa to the articular eminence, will dictate the condylar path or the condylar guidance in the articulation. Okay, the mandible, as you can see here, is mediolaterally is about 15 to 20 mm, and anteroposteriorly it is only about 7 to 10 mm. Okay, it has two poles, the medial pole and the lateral pole. Okay, these are the two poles of the condyle. The medial pole is more well pronounced, the lateral pole is more flat. The actual articulating surfaces extend anterior-posterior to the most posterior aspect. Okay, the articular surface lies on its anterior-superior aspect, thus facing the posterior slope of the articular eminence. This is the posterior slope of the articular eminence, just anterior to the external auditory meatus. This is the styloid process. This is the glenoid fossa. This is the articular eminence. Again, this, as you can see, normally the condyle is in a more posterior and superior position in the glenoid fossa, and the articular eminence dictates the path of gliding or translation of the condylar head. Okay, so now coming to the articular disc that lies between these two portions, that is the glenoid fossa or the mandibular fossa and the condylar head. The disc which is there is a fibrous disc as opposed to a hyaline disc, and this is known as the articular disc because it is articulates between the two joint components. Okay, so the superior surface of the disc is saddle shaped like a horse saddle, you can see, and to fit the cranial contours or the concavity of the glenoid fossa. The inferior surface is concave to fit the condylar head. Okay, so here we see the condylar head. We can see the attachments of the lateral pterygoid muscle, that is the superior and inferior attachment of the lateral pterygoid muscle. And then we also have medial pterygoid muscle, which has the superficial and the deep part. Okay, these are the two muscles that are attached to the anterior surface of the condyle and the neck of the condyle. Okay, now the articular disc is, as I mentioned, saddle shaped, oval, concave underneath. Okay, it is mainly fibrous, and the anterior band is about 2 mm thick and the posterior band is about 3 mm. As you can see, the posterior band is more thick, it is about 3 mm, because normally at rest condyle articulates with the posterior superior portion of the glenoid fossa. Okay, this is the part that can take a good amount of load. The intermediate band, this central portion of the articular disc is very thin, it is only about 1 mm thick. Okay, so here again we can see the lateral condyle muscle, the superior and inferior portion of the lateral condyle, which is attached to the neck of the condyle. Okay, and next, moving on. So the articular disc divides the TMJ joint in toto into two parts, that is the upper compartment and this is the lower compartment, and in between is the articular disc. Okay, so hinge movement takes place in the lower compartment, that is when the mandibular is at rest, when the patient just opens the mouth without any straining. It is a purely rotatory movement around the terminal hinge axis. Okay, and this takes place in the lower compartment, whereas the translatory movement takes place in the upper compartment. Okay, so coming to the attachments to the articular disc, as I mentioned, this is the articular disc, and anteriorly the articular disc is attached to the capsular ligament. This is the capsular ligament which completely encases the TMJ joint, the articular disc, and the synovial fluid. Okay, and anteriorly it is attached to the capsular ligament, anterior margin of the articular and the anterior margin of the articular surface of the temporal bone or the articular eminence. Okay, this is also the attachment to the anterior portion of the articular disc, and anterior inferiorly it is attached to the articular surface of the condyle. Okay, so here we can see it is inferior attached to the condyle, superiorly attached to the articular eminence at articular surface of the glenoid fossa, and to the capsular ligament. Okay, Now, posteriorly, it is attached, articular disc is attached to the retrodiscal tissue. This is a TMJ capsule, what we see at around the neck of the condyle and the glenoid fossa. And this articular disc is posteriorly attached to the retrodiscal tissues. These are the retrodiscal tissues, and this is mainly retrodiscal tissues are the zone of the loose connective tissue which are highly vascularized. So, and also the glenoid fossa in the posterior portion is consists of thin bone, so we cannot have the condyle articulating against the posterior portion of the glenoid fossa, because it will here compress the retrodiscal tissues which are highly vascularized, which can result in inflammation, necrosis, severe pain, and all these things. So always the condyle is supposed to articulate with the most anterior superior position in the glenoid fossa against the slopes of the articular eminence. This is basically the definition of the centric rotation. Okay. So coming to functions, of course, it is a hinge joint, so as well as a gliding joint. Its functions are to stabilize the condyle within the TMJ. Uh, Articular disc also helps to reduce the wear. That is, if there is a direct bone-to-bone contact, there will be severe wear of the joints resulting in ankylosis. Okay, it aids in lubrication of the joint by storing fluid. Okay, so basically it acts like a shock absorber. It has a lubricant, just like any other joint. Now coming to the ligaments of the which are attached to the TMJ. Now there are primary ligaments and accessory ligament. The primary ligament is of course the fibrous capsule, the collateral ligaments, the TMJ temporomandibular ligament, and the accessory ligaments are the sphenomandibular and the stylomandibular ligament from the sphenoid process and the styloid process from the crane. Okay, these accessory ligaments we can see is sphenomandibular and the stylo. This long portion, needle-like portion, is the uh, stylomandibular ligament from the styloid process, and this is the sphenomandibular, which is a shorter spine from which the ligament attaches just above the lingula of the mandible. So these two ligaments help in further supporting the TMJ joint. Okay, what are the prosthodontic implications of TMJ? Now, why TMJ is important in prosthodontics? Let us just see in a few moments. Now, the changes in the mandible and maxilla occur slowly over a period of time. They are not like a sports injury unless there is a trauma or something. These changes happen very slowly, and they are dictated by the presence of the teeth, okay, the health of the joint, the articular component, the articular disc, okay. And so basically, like any joint, overloading of the TM joint also will result in damage to the articular surface, which is a slow and controlled process throughout the life cycle of. Okay, now vertical dimension of the mandible in relation to maxilla is also dependent upon the TMJ joint. Okay, and it is repeated by dictated by repeated position of contraction of the elevator muscles. Okay, so the vertical dimension, as I mentioned, is determined by the elevator muscles, which are primarily your masseter muscle, your medial pterygoid muscle, your temporalis muscle. Okay, these are the three primary muscles that dictate the vertical dimension of the patient, along with the presence of the teeth, and these also have a role or impact on the TMJ. That is, an increase in vertical dimension will cause damage to the joint, and also a over closing or decrease in the vertical dimension will also affect the health of the joint. Okay, this is the masseter muscle, this is the temporalis muscle over here, which is attached to the coronoid process. Okay, now coming to centric relation, as I have told in between, a centric relation is a maxillomandibular relationship which is independent of the tooth contact, in which the condyles articulate in the anterior superior position against the slopes of the articular eminence. So this is the articular eminence, this is the posterior slope of the articular eminence, not of the glenoid fossa. Please don't confuse it with glenoid fossa. The condyle articulate in the anterior superior position against the slopes of the articular eminence. So in this position, the condyle is in a purely rotatory movement in unstrained position, and it is not in contact with the retrodiscal tissues of the posterior part of the glenoid fossa. This is a very healthy position of the condyle as opposed to the glenoid fossa, and that's why this is very important. It is not dictated by the position of the teeth. It does not occur in the natural dentition, but when patient becomes edentulous, this is the landmark or the end point of the condyle that we want when we fabricate dentures or do oral rehabilitation for the patient. Okay, So how does mandible go into centric relationship? So we have the strong elevator muscles that move the condyle disc assembly on the posterior slopes of the articular eminence or the articular tubercle. The lateral pterygoid relaxes now because lateral pterygoid is a depressor muscle. So a lateral pterygoid does not have any role here. Only the masseter, temporalis, and the medial pterygoid, these three elevate the mandible, take it back in the most unstrained position dictated by the anatomy of the disc, the joint. Okay, and when the complete seating of the condyle happens in anterior superior position is when we get the centric relation. So that's why we have to guide the patient into centric relationship. So here we can see the elevator muscles elevate the condyle into the anterior superior position, that is against the posterior slope of the articular eminence or the articular tubercle. Okay, so here is the joint against the anterior superior most position against the posterior slopes of the condyle, and this is due to the action of the primarily masseter muscle and also the temporalis muscle, which is attached to the anterior border of the coronoid process. Okay, so here lateral pterygoid does not have any component play. Most common conditions that affect the TMJ with concern to prosthodontics and complete denture is the occlusal discrepancies. Okay, when teeth are present, we have occlusal discrepancies because of the because of pathology in the TM joint. There is disharmony between centric relationship and the maximum intercuspation, and this is seen in bruxism, bruxomania, when the patient is in stress or any neurological problems that affect, and this will cause problems in the joint. Now coming to the classification of TMJ disorders. Okay, TMJ disorders can be broadly classified into three categories, that is muscular disorders, joint defect disorders, and the degenerative joint disorders. Okay, muscular disorders comprise of those disorders due to the pain in the muscles of mastication, that is elevator muscles that control the function of the jaw, that is the elevator and depressor muscles. So in bruxism, bruxomania, and occlusal, severe occlusal attrition of the teeth, the muscles are the one which take the most load or brunt, and they become sore, and there is tenderness on palpation of these muscles. So this is a muscular disorder in which it's not necessary that a joint is still affected. Primarily these are the muscular disorders which can be treated by giving patients tense therapy, muscle relaxants, uh, antidepressants, and by making the patient aware of this, by modifying the diet of the patient, giving them night guards. Okay, now the second is the joint defect disorders. These disorders are due to the shift in the position of the disc, that is the articular disc does not lie in its normal position due to the shifting of the disc. There are the joint defect disorders, and third are the degenerative joint disorders, which are due to the chronic inflammation in the joint, which destroys the cartilage, causes attrition or perforation of the articular disc and the cartilage that covers the temporomandibular joint. So like in arthritis, rheumatoid arthritis, or any chronic injury. Causes of the TMJ disorders, as I mentioned, are usually there are not many causes of TMJ disorders, mainly due to trauma, due to injury, due to wear caused by age, because of the diet of the patient, uh, and due to eating heavy and hard fibrous foods, usually seen in rural population, older individuals. So because of that, the wear of the teeth will again affect the position of the condyle, and this will cause the soreness of the joint. Okay, injury to the articular disc or to the condyle. It can also be due to chronic inflammation. It can be due to arthritis, and due to certain behavior conditions or disorder like neuromuscular disorders, stress, a patient who continuously chew gums. Okay, there are many classes, various. These are the common things that lead to disorders. So, how do we diagnose these TMJ disorders? Okay, diagnosis is a little difficult because not all the symptoms are known, and many symptoms overlap between different joint conditions. So it is pretty confusing to diagnose the TMJ joint disorders. There is no specific test for TMJ joint disorders. In most cases, we have to take detailed history, we have to see the symptoms, we have to palpate the muscles of mastication, the joint, we have to check the mandibular opening and closing, is it normal, is it reduced, is it, we have to check for clicking, crepitus, and any other symptoms. Okay, so of course we have diagnostic aid, like we need to take OPGs, full mouth orthopantomograph, to see the roughly see the position of the articular disc and the condyle. In severe situations, we can just from OPG we can find out whether there is a problem in the TMJ. We need to take detailed CBCT images of, so which will give a better picture of three-dimensional view of the TMJ joint, the articular disc. So CBCT is the golden standard for uh, radiographic diagnosis. Physical examinations also need to be done of the muscles of mastication, and to check for pain, soreness, muscle hyperactivity. In some patients, masseter muscle will be so much hyper that in overdrive, that you can see the firing of the masseter muscle, the involuntary contractions of the masseter muscle, just by seeing on the patient's face or by placing your fingers on the patient's masseter muscle area. And we can even auscultate or normally hear the clicking sounds, the crepitus. So all these things will help in determining whether the patient has TMJ joint disorder and which type of joint disorder it is. So we have to do physical examination, history, we have to do radiographic examination. Okay, now coming to the treatment of TMJ disorders, usually first thing is, like any injury, if a TMJ disorder is due to injury or due to any pathological conditions like bruxism. So first thing is we have to give rest. Patient should avoid chewing gums or chewing or eating hard food substances that require a lot of effort. Patient should refrain from opening the mouth excessively, as this will cause the articular disc to pop out of the joint space, and will the disc will not return back to the position, and will further keep causing harm to the TMJ joint. uh, Patient will need warm compression, ice packs to loosen the muscles, to reduce the inflammation, to give a symptomatic rest. Okay, and other than that, we can even do infrared therapy, we can do tense therapy, which is a done in physiotherapy to relax the muscles. Okay, we may need to prescribe multiple relaxants like chlorzoxazone. We may need to give paracetamol, PCM, or and other NSAIDs to reduce the inflammation, to reduce the pain if patient is having severe pain. Okay, even in these cases, Botox injections are very helpful, because as you know, botulinum toxin basically causes temporary or transient paralysis of the nerves, which are firing or causing contraction of the muscles of mastication for a limited amount of time, maybe 3 months and 6 months. So it's a mixed mode of treatment. Okay, we have medicinal treatment, we have surgical treatment, we have prosthodontic therapy for these conditions. Okay, in prosthodontic therapies, we have different removable appliances like soft splints, night guards for in case of bruxism and bruxomania, to protect the teeth as well as to prevent the loading to the joint. Okay, we can use hard night guards, soft night guards. We have even anterior positioning appliances in which the mandible is made to close in a more anterior position than maximum intercuspation, in order to create space for the articular disc to be recaptured or to return back to its normal position. Patient has to wear these for a few weeks to few months. Then the last result is surgical treatment, which is often reversible and should be avoided as much as possible, um, where it is not extended too far. Okay, because surgical treatment are very debilitating and can cause ankylosis or irreparable damage. Of course, in some cases it is totally unavoidable. We may need to place or artificial articular disc, silicone disc. We may need to change the head of the condyle in case of ankylosis or severe attrition with a Teflon condylar head. There are many new advancements, and we also have arthrocentesis, which is a fairly good thing in cases of initial joint condition where surgery is not required, where a steroidal lavage of the joint space is done. by injecting steroid directly into the upper joint compartment, and allowing it to drain from the lower joint compartment. So this is also one of the treatments for TMJ disorders. Okay, various other factors that affect the TMJ, as I said, is trauma, the malalignment due to the of the occlusal surface of the teeth due to maybe increase or decrease in VD, or through a defective or the severe erosion or attrition of the occlusal surfaces. In some patients who have habit of nail biting, gum chewing, and as well as degenerative joint diseases like osteoarthritis. Okay. Now treatment, as I mentioned, is again, in cases where the patient still has teeth, uh, we have to rehabilitate the occlusal surfaces of the teeth at the proper vertical dimension. It may be done by giving onlays, it may be removable onlays, or what you call as direct onlays or direct veneering of the occlusal surfaces, or by giving crowns and bridges to the patient. Patient may need to wear occlusal splints. Even some cases orthodontic surgery may be required. Okay, so splints are removable devices which are made using clear acrylic resin, or polyvinyl resin, or polytetrafluoroethylene resins to cover the occlusal surface of the teeth. May use a soft or a hard night guard or occlusal splint to create spacing between the upper and lower teeth to prevent bruxism or night guard. Okay, the primary function of occlusal splint is to provide temporary uh, stable joint position, because when the teeth don't come in contact, they don't cause the condyle to slide in unfavorable position. Okay, and they are used to protect also the teeth from the excessive wear which is already happened. The secondary function of occlusal splint is to stabilize the weak teeth, to prevent the fracture or vertical root fracture of the teeth due to excessive occlusal forces from bruxism, and to distribute the occlusal surface over a large surface area. Okay. uh, now come Now coming to the occlusal appliances, as I mentioned, occlusal splints are of two types, that is the permissive splint and active splints. Permissive splints are also known as muscle deprogrammers. These are basically stabilization splints. Okay, and used to guide the mandible in the proper position according to the centric relation. Okay, so by this way, this prevents the muscles of mastication or the elevator muscles from uh, contracting and forcing the condyle into the habituated position which the patient has developed. So these are known as stabilization prevent. Then we have the directive splints, which are merely anterior positioning appliances. That is, purposefully the mandible is made to close in a more anterior position, like in a protrusive position, so as to allow space for the articular disc. In some cases, the articular disc slides anteriorly out of the joint space and does not return back to its original position. This is called as uh, disc displacement without reduction. In some cases, with the when the condyle opens or glides during opening movements, the disc also comes out along with it, and when the mandible closes or the condyle goes back, the disc also goes back with it. So these are known as conditions where disc displacement with reduction. Disc displacement without reduction is when the disc is unable to come back to its original position in the glenoid fossa. So in such cases, we need to give patient anterior positioning appliances for a few months. So